nurse practitioner student with UAH doing a comprehensive diabetic foot exam. The first part of our exam would be to review our history with our patient. We want to include the last time they've had a foot exam, if they've had any problems since their last visit, to include any foot ulcers, change in their symptoms to include blurred vision, increased urination, change in their eating habits, any changes in medications, any high blood pressure or cardiac disease since their last visit if it has been within over a year. The next part of our exam is going to be to do the foot inspection. We get our patient to slide their foot shoes and socks off. You want to start with just a visual inspection. You want to look for any edema, varicose veins. We want to look for any redness, obvious sores or ulcerations. We're going to check in between the toes for any signs of redness, cracking, which can be indicative of fungus. Also want to check the nail beds to make sure there's no thickening or no signs of increased ingrown toenails. So we want to check the edges of the toes very well. We want to check for calluses. These are thickened areas that can occur on the foot, which show signs of increased pressure and may be signs that would lead to increased signs of ulcerations. She does have a small callus here on the lateral aspect of her small toe. It blanches well, which means no signs of ulcerations underneath. She also has a small callus here on the top of the second toe. Again, blanches well, no signs of ulcerations. I'm going to make sure to inspect the bottom of the foot for any calluses or reddened areas or any ulcerations. The heels, the back of the heels, no signs there. Foot looks good other than those small calluses. The next part of our exam would be our circulatory exam. We're going to check for pulses. We're going to check for dorsalis pedis pulses. She's got nice, strong 2+ dorsalis pedis. We're going to check for posterior tibial. Nice and strong, again 2+. Foot feels nice and warm. We're also going to check for hair distribution to her toes, and she does have nice hair distribution, which are signs of good circulation. Loss of hair, decreased pulses can mean signs of decreased circulation, which can be signs of peripheral artery or peripheral vascular disease. Our next part is musculoskeletal. We're going to check for strength and range of motion. I'm going to get her to pull her foot up and push against me. Nice and strong. Get her to pull her foot back up and don't let me pull down. Great. Nice and strong. Push out and push in. Again, strength in all planes. Check range of motion. We're going to flex. We're going to get her to flex and make sure she can go past 90 degrees. If they have problems getting past 90 degrees, that can be indicative of a tight Achilles tendon and heel cords. When this happens, this can add pressure to the top of the foot, which could lead to ulcerations. We also want to inspect for any deformities. You want to check the arch of the foot, make sure they have a nice curve. Fallen foot in the midfoot can be a sign of Charcot's disease in a diabetic patient. Another good way to check for this would be to have this patient stand on both bare feet to check for any falling of the arch. You want to check for toes to make sure there's no hammer toe or overlapping of toes where they can put pressure on each other to lead to ulcerations. Our next step would be to check the sensory findings of the foot. We're going to do 4 different tests for that. Our first one is going to be to check with the monofilament. This is to check for protective sensory loss, which can lead to ulcerations without the patient knowing it. We're going to get the patient to close her eyes, and we're going to check in several distributions. You want to hold the monofilament at perpendicular angle. You want to put nice pressure and have the filament bend.
Yes. Yes. Yes.
At this point, you want to avoid any
Yes.
calluses
Yes.
because the area can have decreased
Yes.
circulation. Check the top of the foot.
Yes.
Great. She has good sensation with that. We're also going to check vibratory sense. We'll get the patient to feel on her wrist to make sure she can feel.
Yes.
And she can. And then we're going to check for her foot. She's going to close her eyes and tell me when she feels it stop.
Stop.
Great. And I'm going to check it against mine. And I no longer feel any vibration from that, which means she's passed that test. We also want to check for sharp and dullness and sensation. Again, have the patient close their eyes. Tell me if this is sharp or dull.
Dull. Sharp.
Great. And we're going to check for reflexes. You can check knee, and ankle. And she's got good reflexes. So these are all signs that she has passed that show no signs of neuropathy. If she had had any decreased sensation, vibratory, touch, or reflexes, this may be indicative that she is developing a neuropathy, and we would need to further test. Testing can include EMG testing, neurosensory testing, and also make that referral out to the podiatrist or foot specialist for further evaluation. Excuse me. At this time, we're going to do some education. We're going to teach the patient that she needs to inspect her feet daily. When she comes home after a long day, she's going to take her socks and shoes off. She needs to make sure she inspects the socks for any drainage or bleeding. She needs to double check the soles of her shoes to make sure they're not worn in any particular area or have areas that are worn that could allow objects to penetrate easier. She wants to look at her feet after she takes her shoes off to see if she notices any redness immediately after taking the shoes off that may show that the shoes are too tight fitting and may be causing areas of pressure. Again, we need to teach them to inspect between their toes, just like we did. And they also need to inspect the bottom of their feet and under their heels. And they may need a mirror to accomplish this. So it's recommended the patients get a long-handled mirror that they can hold and to inspect the foot. Other thing is, as far as daily care, you want to make sure the skin stays nice and moist and use a moisturizer. You do want to avoid that between the toes. Because that is an area that stays damper, but the heels, sole of the foot should be nice and clean and stay moisturized. As far as bathing, when you go to take your bath, you want to check the temperature of the water with your elbow before inserting the feet in case there is any loss of sensation to avoid burns that could lead to further complications. Excuse me. Also want to discuss smoking. If your patient is a smoker, we need to discuss smoking cessation and the effects that can have on patients with their circulation and increased risk for infection and healing. Also need to limit alcohol intake. Patients should be taught to make sure their blood sugars stay within a normal range. If patients are having any issues, concerns, notice foot ulcers, they need to contact their provider immediately for further evaluation. With this patient, she's had a normal foot exam. We would follow up in 1 year. If she had had any signs of neuropathy without deformities or a history of ulcerations, a 6-month follow-up would be recommended. And if she's had any prior complications to include ulcerations, deformities of the foot, then we need to check her every 2 to 3 months. This concludes my diabetic foot exam.